Yeah. You open the meeting, then I will follow.
Okay, good.
Yeah.
She didn't take the call. I don't know, maybe this is.
It's okay.
No problem.
You can just drop in the message on WhatsApp.
Yeah.
Maybe you can share the link.
Okay.
We are live.
So, good evening, friends. Welcome to the Journal Club meeting, second Journal Club meeting of second episode of Maharashtra Ophthalmological Society and BOA Journal Club meeting. Today, we are lucky to have world-renowned panelists like Dr. Srinivas Rao, Dr. Nikhil Gokhale, and Dr. Somshila Murthy. And the topic for today's discussion is management of progressive keratoconus. And without any wasting time, I request Dr. Vaishal Kenia to take over and introduce the panelists and the speakers. Over to you, Dr. Vaishal.
Thank you so much. And this is a second meeting. And as Dr. Santosh said, this is a very interesting topic. In a cross-link cornea, still if a second time cross-linking is done, how is the result? So that's really fascinating. And we have a galaxy of faculty. And it would be a very nice deliberation today. And without further ado, I would ask Dr. Parul to introduce the faculty today.
Thanks, Vaishal. So the topic for today's journal club is the safety and efficacy of repeated corneal cross-linking in progressive keratoconus, which was published in Cornea Journal. And the faculties that we have who are going to discuss this article are Dr. Srinivas K. Rao. So everybody knows Dr. Srinivas K. Rao. He was a former consultant at Shankar Nethralaya Eye Hospital in Chennai for 15 years, followed by now he's into currently he's into private practice at Darshan Eye Clinic, and he's a world-renowned cornea figure. So welcome, Dr. Srinivas Rao. The second faculty is Dr. Somshila Murthy. She is also a consultant in cornea and uvea at L.V. Prasad Eye Institute, and currently now she has moved her base to Mumbai, and she's currently the director of Shantilal Sanghvi Institute of Ophthalmology. Welcome, Somshila. And we have Dr. Nikhil Gokhale, who's our own BOA and MOS member. So I think everyone knows him. So welcome, Dr. Nikhil. And with this, I would ask Dr. Shubhangini to introduce our speakers, these students, and the statisticians. Dr. Shubhangini, ma'am.
Thank you, Parul. Here I am to introduce our PG students from Dr. Bala Saheb Vikhe Patil Rural Medical College, Loni. The presenter will be Dr. Akshay Divte. He is a junior resident third year. And second will be the Dr. Rohit Afle. He is also a third year resident. And he will review the short literature about the same article. And I would like to introduce after that Dr. Sengupta sir, and he is a retina surgeon and head of Sengupta Research Academy, Mumbai, and Dr. Siddharth Kesarwani from ZNK Eye Center, Mumbai. So here with I hand over to Dr. Parul.
Akshay, can you just share your slides for the journal club?
Yes, ma'am.
Ma'am, Dr.
So, good evening, everyone. Should I start?
Yeah, please go ahead.
Akshay, go ahead.
So, good evening, everyone. On behalf of me and Rohit, I would like to thank Maharashtra Ophthalmological Society and Bombay Ophthalmology Association for providing us opportunity for presenting this journal. Without further ado, I'll start today's journal topic. So today's journal topic is safety and efficacy of repeated corneal collagen cross-linking in progressive keratoconus. The study was done by Ofri V. Berar and colleagues and was published in Cornea Journal in April of 23. The impact factor of this journal is 3.152. So keratoconus is a potentially progressive and visually impairing disorder. Kennedy et al. Reported its incidence was 2 per 1 lakh population, but the numbers are higher in the modern era and reported at 13.3 cases per 1 lakh population in a nationwide study in the Netherlands. Corneal collagen cross-linking was introduced in the early 2000s by Wolensek. Epithelial off CXL procedure has become the standard of care for progressive keratoconus in many countries. The accelerated protocol with irradiance of 9 milliwatt per centimeter square for 10 minutes was shown to be effective in mild to moderate keratoconus. So the aim of today's journal is to report the safety and efficacy of repeated accelerated CXL for progressive keratoconus after previous CXL. It is a retrospective study design, and the inclusion criteria included consecutive patients diagnosed with progressive keratoconus previously treated by CXL and requiring repeated CXL during a period of 2011 to 2020 at Sheba Medical Center in Israel. So the keratoconus was defined as progressive if there is more than one diopter increased in steepest radius of curvature of the anterior corneal surface, that is Kmax, or a decrease in minimal pachymetry of more than 10 microns within 1 year, visual acuity of one or more line decrease, or change in refraction of 0.5 diopter or more. Imaging. So prior to imaging, contact lens wearers were instructed to discontinue contact lens before examination for 72 hours for soft contact lenses and 2 weeks for rigid gas permeable lenses. Patient underwent tomographic imaging performed using a serious tomography that combined placido disc topography and Scheimpflug tomography. Surgical technique. After installation of local anesthetic, debridement of epithelium around 9 mm was done. Isotonic or hypertonic riboflavin was instilled every 2 minutes for 30 minutes. UVA irradiance with accelerated illumination device at 9 milliwatt per centimeter square for 10 minutes was done after confirming a minimum corneal thickness above 400 micrometer. Supplemental riboflavin was applied every 2 minutes. Eye was irrigated with BSS and BCL was applied after the application of dexamethasone sodium phosphate 0.1% and moxifloxacin hydrochloride 0.5% eye drops. Pre-operative data and follow-up. Patients were observed on 1 day post-operatively and 1 week later for bandage contact lens removal as per corneal reepithelialization. Further follow-up appointments were performed at 1, 3, 6, and 12 months post-operatively. Data was abstracted on manifest refraction, best corrected distance visual acuity, tomography parameters, and slit lamp examination. Statistical analysis were performed using IBM SPSS Statistics version 24. Changes in BCVA, Kmax, and minimal pachymetry were compared using a parametric matched pair analysis. The overall significance level was set to an alpha value of 0.05. Results. 10 consecutive eyes of 9 keratoconus patients, out of which 4 were females and 5 males who developed progressive keratoconus after CXL were taken. Mean age at keratoconus diagnosis was 20.2 plus minus 6 years. 4 eyes had haze and rest were clear post CXL. Atopic background was seen in 5 patients. It should also be noted that in eye number 5, the time from diagnosis of keratoconus to CXL1 was just 0.5 years, and from CXL1 to CXL2 was 0.65. Similarly, in eye number 10, the time from diagnosis to CXL1 was just 0.28 years. Visual outcomes. The mean best corrected distance visual acuity was stable throughout the entire follow-up and was 0.52 plus or minus 0.2 in decimals before CXL1. It improved to 0.58 plus or minus 0.3 in decimals at the last follow-up. One eye, so eye number 6, was diagnosed at the age of 10 with low visual acuity, which further deteriorated on follow-up. No data is available on patient 8 as the patient was mentally depressed. Kmax progression. The mean Kmax before CXL1 was 60.4 plus or minus 3.6 diopter. Before CXL2, Kmax progressed significantly to 62.2 plus or minus 6.3 diopter with p-value of 0.018. At the last post CXL2 follow-up visit, the value decreased significantly to 60.3 plus or minus 6.4 diopter with a mean progression rate of 2.8 plus or minus 2.3 diopter. It should also be noted that in I-10 and I-5, follow-up only till 6 months after CXL2 was available. And for I-1 and I-9, only for a year it was available. Rest of the eyes were followed up for 2 years. The mean minimal pachymetry before CXL1 was 464 plus or minus 27 micron. Before CXL2, the minimal pachymetry was 427.7 plus or minus 38 micron, which was significantly lower than before CXL1. Minimal pachymetry was stable after CXL2 with a mean value of 415 plus or minus 43 micron. The mean topographic astigmatism was stable throughout the follow-up time. CXL is relatively safe, but may result in corneal haze, scars, corneal edema, endothelial folds, irregular epithelium, and decreased visual acuity. Haze is reported in up to 57% of the cases, but usually decreases during the first year. In this study, 4 eyes had corneal haze after CXL1 and remained stable with no worsening after CXL2. No other complications were seen in this study. This study reports the outcomes of corneal and visual parameters in eyes requiring repeated cross-linking for stabilization of progressive keratoconus after initial CXL surgery. In this study, it was found that repeated CXL can stabilize keratoconus progression with no additional risk of complication. An atopic background is common among redo patients. In this study cohort, 5 patients had clinical records of an atopic background. Despite this, clinical impression is that the atopic background prevalence is higher and possibly under-recorded. Various studies mentioned in this journal include a study done by Greenstein et al., who found corneal collagen cross-linking effective in treating progressive keratoconus. Treatment failure and keratoconus progression at 1 year after CXL were found in 2 to 8% of the cases. Similar results are found in this study. Schuyler et al. Found the number of corneal transplants for keratoconus reduced to half after the introduction of CXL in 2 Canadian provinces. Anton et al. Reported progression of 3.17% of cases. He reported that CXL redo with Dresden protocol after first CXL is safe and effective. Kuchler et al. In a retrospective analysis of 61 eyes of 56 patients with Kmax value of more than or equal to 58 diopter found that 23% patients showed progression of keratoconus after CXL, indicating that high Kmax values is a risk factor for the progression of keratoconus. In this study, the initial Kmax was 60.4 plus or minus 3.6 diopter, which could be the reason for a high progression. Study done by Jano et al. Found there is a decrease in pachymetry after the procedure and stabilization at 1 year. Similar findings were found in this study. Minimal pachymetry progressed before repeated CXL and was stable after the second procedure. Hatch et al. Found prevalence of progression in patients after CXL to be about 2 to 8%. He showed that risk factor for disease progression is younger age. Cohort of this study was also relatively young. Youngest was diagnosed with keratoconus at the age of 10. Study done by Rice-Cup et al. He was the first to report repeated CXL on 2 patients who showed continuous keratoconus progression. Hafizi et al. Used accelerated protocol and found it to be effective. Hupping et al. Showed stabilization of keratoconus for 24 months in 12 eyes who underwent repeated CXL with iontophoresis. Tahan et al. Used the accelerated protocol in all redo patients, but the first procedures were variable. All previous reports mentioned have different baseline features, surgical techniques, and outcomes. This study cohort is the only in which all the first procedures were EP-off and the repeated procedures were all EP-off with the accelerated protocol. The limitations of this study is small cohort at a single center, retrospective study design, variable follow-up of few patients. To conclude, despite the limitations of this study, AP of repeated CXL is safe and excellent treatment option when failure of the initial CXL is diagnosed, even in young patients. Thus, this procedure may prevent the potential visual deterioration and need for keratoplasty. The accelerated protocol is safe and effective treatment as a redo procedure for a relatively long period. MARI evaluation. Method. Study question is well defined. Sample size is small of just 10 eyes. Study period is well defined between 2011 to 2020. And study design, it is a retrospective study design. Assignment. Due to retrospective study design, there was no randomization or blinding in the study. Assessment. The primary outcome measure was the change in maximum keratometry value after repeat CXL, changes in best corrected visual acuity, manifest refraction, and corneal thickness. Results are appropriate statistical analysis performed using IBM SPSS Statistics version 24. Interpretation. The results indicate that repeat CXL can reduce Kmax values, arrest the progression of the disease, improve visual acuity, and manifest refraction in these patients. Further research is needed to evaluate efficacy and safety. Extrapolation. This was a retrospective study with a small sample size. A randomized control trial in a larger population with longer follow-up is needed to confirm its safety and efficacy. In few patients, time interval between diagnosis and treatment was very short. Data and case elaboration of these patients should have been done. With this, I would like to hand over to Rohit for review of literature.
Rohit, are you there?
Yes, ma'am. Good evening, everyone. Now I'll continue with the review of literature regarding repeat CXL procedure. So various progression criteria for keratoconus are defined. So progression of keratoconus prior to collagen cross-linking is defined as an increase in the maximum keratometric value, that is Kmax, by more than 1 diopter in 2 consecutive measurements using the same imaging method, and a decrease of more than 20 micrometer in pachymetry measured at least 3 months apart. There is ABCD grading and progression system by Bellin et al., which contains A, which stands for anterior corneal curvature, B for posterior corneal curvature or elevation, C for minimal corneal thickness, and D for best corrected distance visual acuity. So this grading system is installed in Pentacam software and enables multifactorial detection of possible deterioration. The criteria for treatment failure or progression of ectasia after primary CXL, these include an increase in Kmax value of more than 1 diopter, deterioration of BCVA after first 6 post-operative months. These criteria could be defined as a sign of progression and an indication for repeated CXL if no contraindication exists for that. The corneal thickness is expected to decrease, especially in the first months after CXL, due to packing of collagen fibers during the corneal remodeling. Any cause of pseudo-progression should always be excluded before making the decision to repeat the treatment. So the causes for pseudo-progression may include measurement errors, superficial punctate keratopathy, corneal stromal scarring, uses of contact lenses, and conditions like vernal keratoconjunctivitis. Various studies are done regarding diagnosis of progression after treatment. The reports by Siderodi H. et al. And Hashemi H. et al. Have demonstrated a good repeatability and accuracy of curvature measurements with Scheimpflug tomography after CXL, which would suggest that preoperative criteria for progression could be applied postoperatively as well. But studies by Antonois R. et al. And Mencusi R. et al. Reported that Scheimpflug corneal thickness measurements after CXL are not as reliable as with optical coherence tomography due to light scattering. So according to them, OCT is a better method for measurement of the corneal curvature postoperatively. Risk factors for CXL failure include a preoperative Kmax value of more than 58 diopters, a younger age group of less than 35 years age, tendency of eye rubbing, allergic conjunctivitis, corneal thickness of less than 400 micrometer, and a more eccentric cone in keratoconus. So various studies are being done previously regarding the repeat collagen cross-linking. So these studies, in these studies, the cause for ectasia is the pediatric keratoconus, So study done by Abozat et al. In 2019, they studied a single case of pediatric keratoconus in which the primary protocol was EP on accelerated CXL with intacs, and the repeat protocol was EP on accelerated CXL for 160 seconds at 45 milliwatt per centimeter square. The duration between the two procedures was 1 year, and after 2 years of follow-up, they found a stable Kmax values. A study by Mazzotta et al. In 2018, the 4 cases of repeat CXL were studied. In this study, both the primary and repeat protocol was EP of CXL with Dresden protocol, and the duration between the two procedures was 3 years. And after 1 year of follow-up, of 1 year after the second procedure, they found a stable Kmax value. In a study by Caprossi et al., 5 cases of repeat CXL were studied. In this study, the primary protocol was EP on CXL, and repeat protocol was EP of CXL with Dresden protocol. The duration between the two procedures was 18 to 24 months, and after 1 year of follow-up, stable keratometric values were seen. So the further studies, the primary and repeat protocol both were EP of CXL. So in Hafizi, a study by Hafizi et al. In 2014, they studied a single case of keratoconus with primary and repeat protocol of EP of CXL. The duration between the two procedures was 4 years, and after 2 years of follow-up, they found flattening of cornea and better visual acuity. Other studies by Reiskap et al., Hoyer et al., and Agarwal et al. Also studied various cases of ectasia due to keratoconus in which repeat CXL was done, and after follow-up of 1 to 2 years, they found stable keratometric values. A study by Anton et al. In 2015, they studied 7 cases of repeat CXL, in which the cause for ectasia was keratoconus in 6 cases and post-LASIK ectasia in 1 case. So here the primary and repeat protocol both was EP of CXL, and after 1 year of follow-up, they found stable Kmax value and stable visual acuity. These are the studies in which the primary protocol was EP on CXL, and they found more progression in this in the patient. So the study by Soeters et al. In 2015, they studied 5 cases of repeat CXL, in which the primary protocol was EP on CXL, but the repeat protocol used was EP of CXL, that is Dresden protocol. The duration between the two procedures was 10 months to 1 year, and after 1 year follow-up of second procedure, they found decreased Kmax values in 4 eyes. In a study by Turhan et al. In 2020, they studied 12 cases of repeat CXL. And in this study, the primary protocol was EP on for 9 eyes and EP off for 3 eyes. And repeat protocol was accelerated EP off protocol for all the patients. So after the mean duration between the two procedures was 19.3 months. And after a mean follow-up of about 36 months, they found that the Kmax regressed in 8 eyes, the Kmax remains stable in 2 eyes, and the Kmax progressed in 2 eyes. So various theories have been put forth to explain the cause of progression. The regeneration of collagen fibers in the stromal layers lasts approximately about 2 to 7 years. The collagen cross-linking can significantly increase its half-life when there are no hormonal changes such as those occurring during pregnancy. This implies that almost 10 years after CXL, the collagen fiber should have been renewed, and the cornea may be less rigid and more vulnerable to possible changes.
Rohit, is it all, or
Yes,
we
ma'am.
still have something more?
Ma'am, this is the last slide.
Okay, yeah.
So this hypothesis could explain the progression in some patients after stabilization, despite the fact that cornea becomes more rigid and the likelihood of development ectasia decreases as the time passes. So CXL has been widely used in corneal ectasia management only in the last decade, and the future studies with more than 10 years of follow-up are expected to provide an answer whether this theory could be supported or not. Thank you.
Thank you, Akshay and Rohit, for a very wonderful presentation and the review of literature. So with this, myself and Dr. Shubhangi Nigwekar from Loni would be coordinating the whole discussion. So, Dr. Rao, I just needed, what is your comment on this article, and how should we interpret this article?
No, I think basically for the position of cross-linking in keratoconus is not perfect, but it's all we have, because if you don't do this, we know for sure that the natural history of a cone is that it progresses, and surgery comes with its own share of problems. And even if you're trying to regularize the cornea by doing a ring, or if you're trying to, use an eczema to smooth it out, it still doesn't address the issue of progression itself. So cross-linking is the only one that can do that. And so if it works the first time, then there is theoretically no reason why it shouldn't work the second time. And it's good to see this article, which kind of confirms that theoretical concept, that if needed, you could repeat it again. The only point of interest in this article is some patient who's like 30. I'm quite puzzled that a 30-year-old should progress after an initial cross-linking. That's kind of, I find that a little difficult to understand.
Thank you, sir. Dr. Somashila, your take on the article?
Yeah, hi, Parul. So most of the points that Dr. Eskira mentioned, I think that the older patient, the 29-year-old, was a patient with Down syndrome as well, or maybe with atopy. One of those two are the older patients. That's what they mentioned later in the discussion. So like how I'm sure Sabyasachi knows that, like how many of the reviewers would say no new information in this article. So then you wonder that why they published it. But I think because the literature is very sparse on repeat cross-linking and its results. So that way it's good to have this to add to the body of literature of repeat cross-linking and its results. But in terms of the design, typical things, Akshay, and I think that you should also analyze when you say that the best ideal way of having a study is to have you said it's a randomized control trial, I think. How will you have that? So what do you do? In about 10 years, they had 12 or 13 patients. And they did cross-linking. They waited for a period of 0.5, half a year, I guess, or 0.3 they wrote one place, and then they wrote 0.5 somewhere else. Up to 2 years or so, and then they cross-linked. So you have 13 patients these many years. So how will you randomize them? So when we say RCT, we just say RCT for everything. That is not the answer for these diseases. We have to look at real world data, what actually happens in the real world. So I wouldn't even put that. You can't have an RCT on such a. So from the statistics point of view, one other thing maybe youngsters like you should know is that whatever they've written, the mean, standard, deviation, this, that doesn't have that much meaning because the sample size is very small. So when they say that the Kmax was, I looked at the table which had all the patients and looked at that data. That is the most useful part of the study. So that was my main take on this article. There are many other ways of looking at it, but I don't want to monopolize the discussion. So the 2 points I had to make, that it is again, as Dr. Eskira said, that it is confirming that you can safely do repeat cross-linking. They're saying effective, but they never waited, right? So supposing at 2 years you saw that it had progressed. Supposing you had not cross-linked this patient, okay, patient refused or something, said, I don't want you to do it. What would have happened? We don't know. Maybe that was the end point. So in terms of efficacy, they can't conclude that it was efficient. Efficient compared to what? So they can't conclude. There's no way to conclude also. They can't prove it in any other way. So that's okay. So these are the 2 points that I wanted to make.
Thank you, Dr. Soma. Ma'am, we can't hear you. You're muted, I think.
Yes. Audible?
Yes.
Yeah. I would like to ask Dr. Nikhil about this opinion about this article. What is his perspective about this article and what is his experience?
Yeah, so I think few points which I thought were important. One was they said an increase of Kmax of 1 diopter. So I think as practitioners, we need to be careful because in advanced keratoconus, the variability, inter-test variability of even a pentacam or any Scheimpflug machine is fairly high, and it has been already published. There are a few publications which say that it could give as much as 2-3 diopters of variation could be there if you do multiple tests on the same patient. So one practical point is that it's very easy to prove on the second visit the patient has progressed if the doctor wants to prove that progression is there. So I think if we are unaware of this fact, we might sort of mistreat patients. So be careful whenever you do multiple tests to be sure that, you know, the real thing, what is happening. Second is that, again, like pachymetry, they said 10 microns. So I have had patients with C3R where, you know, the pachymetry is fluctuating at multiple visits. So I think we need to take the data with caution and try to do a trend analysis. So you keep monitoring these patients and keep looking at what is happening. Don't go by one or two values which suddenly, you know, overshoot or undershoot or make you feel that this is progression. The other thing I was surprised is that one of their patient had repeat C3R at 0.6 years, which is possibly 6 months or something like that. So we all know that initially following a C3R, there are most patients at 1 or 2 months may have some worsening like picture because of some changes in the corneal stroma and hydrational changes or whatever, keratocyte apoptosis and things like that. So it's a little, I don't know, maybe there was a gross change, but one has to be very careful of trying to do a repeat C3R so early on. The other factor was that we also need to look at certain risk factors. For example, most of these patients, at least I have done 2 of my own patients where I had done a repeat C3R, which are about maybe around 4 to 5 years following the original procedure. And initially they had flattened and then there was slowly a trend reversal after a few years. I think many of these patients, especially in females, they have hormonal changes, and polycystic ovarian disease is pretty common in these patients. And maybe that there is something to do with the hormonal changes. I mean, so we need to at least ask a history and try to work them out. And for example, recently I had a patient who turned out to have hyperprolactinemia and there was some microadenoma or things like that. Of course, rubbing, we are all aware that we tell patients, if you keep rubbing your eye, maybe even the CXL won't work, or if you have Downs or some disorder where they keep rubbing, it may not work. So I think we need to take all these messages with caution and be really sure that it's progressing. And then, you know, maybe worthwhile trying to do a repeat C3R. What this article has, of course, shown that it is effective. The other question always remains is whether you want to do a Dresden protocol or you want to do a quick cross-linking, because some studies do mention that maybe the conventional one may be a little better than the fast C3R for at least, you know, maybe the results. But again, that's something that one could keep discussing. It's, I mean, you know, that's some of my points.
So, Nikhil, what is the earliest time that you would intervene? Suppose if you see an early progression in the immediate post-op. So what is the earliest time that you would say, okay, this is a case of progression, I would consider it to be a progression and not a pseudo progression. It's not a steepening because of the treatment. So how long would you wait after the first treatment?
Yeah, so see, if, for example, if a patient has had C3R and you find that he's just progressing, or, you know, like at every visit, he's just getting worse, maybe every 3 months or whatever. So we need to also keep in mind that was the C3R done in a, you know, proper way. That is one factor which also we need to consider, because at some places there may be, you know, some technician is doing a C3R and or something like that, or maybe the energy calibration was not correct or something wrong with the technique could also need to be kept in mind. At least the patients I have seen are those where it seemed to work and then after a few years it seemed to go back and started worsening. So if there's absolutely no effect, there could be non-responders, I'm not aware, but it could also mean that maybe the initial procedure, something has gone wrong. We have to keep that factor in mind, possibly at least.
Thank you, Nikhil. So we'll have Dr. Sengupta and Dr. Siddharth.
Can I ask a quick question?
Yeah.
Just a quick question. Lysyl oxidase levels are known to be very low in severe keratoconus. So all these K-conus patients were more than 60 diopters. So in such severe keratoconus, doing a repeat cross-linking, how efficacious, as Dr. Somashila said, is a question mark. So what is the panelist opinion and comment?
Dr. Rao? Okay, Soma.
I mean, if you have a documented progression, the options are what? Basically, sit and watch and see him go down. Or you could do something, if you think you can't get him on a good contact lens with a 60 diopter cornea, then there's no point in repeating the cross-linking, or if he's intolerant to the lens or if his lifestyle doesn't suit a lens, then I would basically go ahead and operate. If he's progressing, losing vision, I would operate. But I would give him this option that if he has decent vision at this point with his contact lenses, then I would try this. I figure I have nothing to lose, because
Absolutely.
in my own series, I think we looked at about 568 patients, about 22, if I'm not wrong, progressed. And of them, 14 actually needed surgery because there was tectonic integrity loss, there was extreme thinning. But in about 9 patients, I think we had to recrosslink, and all of them did well. So in terms of, they had about, I think, an average follow-up of 2 to 3 years. And they did well. We didn't have any complications. So I figure I have nothing to lose. I would offer it to him. If it doesn't work, I always have surgery as a backup.
Vaishal, the also
Right.
other factor you have to consider is the corneal thickness. For example, with 60 Kmax, you could have a patient where the cornea is extremely thin, and you could have a patient where the cornea is
Agreed.
extremely thick. Depends on what it starts with. So if you have good thickness, I think it's worth trying as a rule, probably.
Yeah.
Actually, now with the sub 400 protocol, thickness may not be much of an issue. I mean, I would still offer it to him even if he was 320 microns, for instance. I've used the Efficacy protocol now for some time, and I think it makes sense. So
Makes sense.
that 400 cutoff is not a rigid barrier at this point, for me at least. Yeah.
I think Vaishal has asked a very important question. And Vaishal, for me, the answer would be that it would be based on the individual patient in front of me, the age, other risk factors, and the parameters that the eye has, as well as what is the goal. If I do a repeat cross-linking, is, as Dr. S.K. Rao said, what is a visual rehabilitation for the patient? So these 4 questions, if I have answers to, then I make a surgical plan or a non-surgical.
Very nice. Thank you so much.
May I ask a question to Dr. Somashila, that what is the protocol for according to the severity of the keratoconus? Is there any protocol?
So do you mean, do we?
So how you manage the this keratoconus patients with the help of CXL according to the severity of the keratoconus? Means mild, moderate, severe, advanced. Means presentation will be various. So many times patients come in advanced condition. Still, are there any protocols?
So I think that basically, if I understand the question, I understood what you're saying, but I just would like to highlight that before we even take up the patient for, especially if it's the severe or any keratoconus, number one is to make sure that we're taking care of the risk factors such as allergy. So if the patient has severe allergy, we first treat that very well. And second question that we need to answer is that how are we going to visually rehabilitate the patient after the cross-linking, especially with regards to the advanced keratoconus. So if I have an option for that, the patient can wear a contact lens, or with spectacles, the vision is going to be okay. Or I can plan, say it's a higher refractive error, and I can plan phakichiral safely for this. It's a grown-up patient. So if those are the answers, then I would do cross-linking for these cases. There is no real difference in the way I approach the cross-linking, except for the taking into account the pachymetry. As Dr. SKR said, that based on the pachymetry, if it's sub 300 or if it's sub 400, then you can decide on the duration of cross-linking energy that you're going to apply. So those would be the differences. Otherwise, even if it's mild, moderate, or severe, if I know that I can improve the visual acuity in some way, I would go ahead with cross-linking for these patients.
Thank you, Soma. I think we'll just go ahead with the statistical comments from Dr. Sabyasachi and Siddharth.
Siddharth has also joined.
Dr. Sengupta?
Yes, I'll go first. So I'll just share quickly some of the the paper and the annotations. Just a second. Yeah, so some so the disclaimer is that I'm more of a physician than a statistician, though I'm not trained as one as well. So first thing is that I'm sort of confused when I look at the abstract, because they don't define what is progression of keratoconus in the abstract itself. It must be there in the abstract, because most people will read only the abstract, but then they say for significant progression in keratoconus, but the method is just one sentence. It's just too small for people to understand what they're really doing. In the results, I think it's very also important to mention when the recurrence happened. after the first CXL, right? So that value is actually 3.1 years or something like that, right? So it happened after 3.5 years, like Nikhil sir said, some of his patients had after 4 or 5 years. So, so that should have really been given in the results as well in the abstract. Also, post repeat CXL follow-up was 2 years, right? So when the recurrence is happening at about 3 years, then following up patients should at least happen till 3 years time point, I would think, right? So currently, though it is only 10 patients, still that follow-up is, I think, woefully short to say that this has succeeded, So at least the longer follow-up matching what the pre-CXL, the interval between the first CXL and the recurrence, that at least that much period of follow-up should have been there, right? So then that baseline, that is before the first CXL, that Kmax is 60.4. How much did it increase? How much did it decrease by? So typically there is some flattening, and also those individual curves, that graphs shows that most people had some amount of flattening after the first CXL, and that is typically seen. A little bit of flattening does happen, but then they don't tell us where it went down to, right? So they say that at baseline it's 60.4, and before repeat CXL it was 62.2, right? So where did it go down, right? And if you look at the definition of progression, they say at least one diopter progression should have been there. So if progression, post progression, if it's 62, that means that value was 61 or somewhere around that, right? At least one diopter. So they don't tell us from 60 it became 58 and then it went to 62 or something like that. So that value is again missing. It is not also given in the main text. So we don't know where it dropped and then where it went back to. So that's again a little bit confusing. When you look at the where the definition of progression, do you agree with this? So I think Nikhil sir has already brought this up. So do you agree with this on a clinical basis? And so there is a lot of variation which keeps happening in patients. Though I'm not a corneal surgeon, but I do see some of these statistics on and off. When you look at the results, they say there were 124 patients over 10 years, right? Or so it's about 12 patients a year, isn't it? And so that's just one patient per month. So this overall, the cornea clinic or whatever they're seeing, they are a low volume center, isn't it? So Dr. Rao has already told us that he has looked at about 560 patients. I'm sure that is not over 10 years. That's probably over 5 years or so. So this is a very low volume clinic, and no wonder that they have about 10 cases to show for this. I think this I already brought over, where the mean time between the CXL1 and proven keratoconus progression, which required repeat CXL, was 3.1 years, right? Plus or minus 1.8, and post CXL follow-up is only 2 years. So when this is almost a year lesser than what we should, ideally have. So, whether this really works or whether this is going to again worsen after another year is something that we now, at present don't know. So, and I think this I've already brought up, right? So look at the definition. When you look at the definition of progression, more than one diopter worsening was there, right? So if it's 60, at baseline it is 60, and at pre-CXL2 it is 62. But what about, in between, what happened is something that has not really been given. So these are smaller numbers and only 10, and these means probably don't make a lot of sense, but still, to get a sense of what is happening, they should have really given this. So I think these are some of the points that I wanted to make out.
Thank you, Dr. Sengupta. Siddharth, are you there?
Yeah, I'm there.
Yeah.
And thank you for having me. And it's a very interesting case report series. My take on it is, see, when you have a non-normally distributed data, it's very difficult to apply statistics to it. And if you have a cohort like this, where you have 10 patients, you may not be able to find the mean and apply it to the general population of patients at large. But how these series help is that because there are 10 cases, you can see which one of your, suppose you have a case patient, you can match it with one of the patients in the series. So if you have 10 patients, you can see if one of your patients matches this, and then probably it gives you some prognostic benefit over that. The other thing is that, as Sabyasachi pointed out, that the endpoints or the definitions are not clear. So for any interventional studies, if you want to extrapolate it to the rest of the population of patients, you need the start points and end points to be well defined. Now, what do you do about things that are not common? As you know, that this point kept on coming again and again. These cases are rare. Recurrence is rare, so you won't find that many people. So yes, these are rare, but it's not impossible to do a randomized controlled trial. So you can have a multi-centric study wherein there are collaborators who collaborate with each other and pool in their cases. And it may take a little longer than the regular common cases, but in the end, you will have an answer. The other way is when you have so many case reports, like in the review of literature also was there. When you do the meta-analysis of all these data, you will have some take-home messages. So yes, you can pool in data, and in two ways you can analyze them. One is to randomize the patients at different centers with a common protocol, or to meta-analyze these cohorts which are being reported. So you can have some answers, but the best way of using these studies is to try and match the situation of a particular patient to the situation of one of the patients in the study. That's how you can take home some messages out of it.
Thank you, Siddharth.
May I ask one question to Dr. Rao sir? That how often these redo procedures are needed after CXL? What is your experience, and what are the criteria for the indication for that you take?
Like I said, in mine, the data was from 2009, and I looked at about 568 eyes which had follow-up. Some of them didn't turn back for follow-up. Out of that, it was a 6.3% incidence of progression, of which 9 of the 24 eyes, I think, needed the cross-linking. The others needed corneal transplantation. So it's not uncommon. So these days, I tell people there's a 5 to 10% probability that you may progress even after the cross-linking. And if I'm doing a 10-year-old child or thereabouts, I tell them that most likely you will need a cross-linking repeat after some time. Because in children who present at 10, it's my understanding that the disease is quite severe, as opposed to somebody who presents to you when he's 23 or 24. So the links that you create may not last the corneal remodeling that happens in the cornea itself. So the links will go away and the child will need something when he's 16 or 17. Now, the interesting thing is that there is no data in human corneas regarding collagen turnover. We know the exact turnover time of articular collagen in the joints. We know the collagen in the skin, how often it turns over. We know that in the bone, but we have no solid data for the cornea. There is one report saying that it could be 6 to 7 years, and that's widely cited in subsequent articles. But then there's a paper which goes back and looks at that original citation, and then they find that 6 to 7 is more of a anecdotal thing that those authors believed, and they don't really have data to support it. So we don't really know how long it takes for the collagen to turn over. If you know that, then you may have an idea of how long your cross-linking will theoretically work. So the indication for it is, like we've been discussing, somebody who's progressing both on topographic metrics in terms of visual acuity, and most important for me, in terms of quality of vision. Sometimes the patient will come back 6 months later. On paper, he may be the same 612 that he was, but he'll tell you very clearly that his quality is deteriorating, and these are the people you want to follow up more closely.
So, sir, I just wanted to know,
Yes.
from all the panelists, that what is the preferred the protocol that you use for primary treatment as well as for the retreatment? So whether you use an epi-off, epi-on, you use a classical resident protocol, or you're using an express technique. So, Dr. Rao, starting with you.
I always do the epi off. Early on, when I started in 2009, I did about 10 patients with the epi off. I didn't with the epi on, and I didn't find good results. But at that time, we weren't using any special kind of riboflavin to enhance its penetration. We were just using a little more of the topical anesthetic. Maybe the results would be better if you have the riboflavin incorporating some epitheliotoxic stuff, or if you're using iontophoresis. But I do the epi off, and I do the accelerated protocol, 10-minute exposure. And this is what I've been doing for a very long time. And it doesn't change if I'm doing a retreatment. It's exactly the same as for the primary procedure.
For all age group, right, sir?
Yes.
Dr. Somashila?
Yeah, exactly the same, including the experience with the epi on which we had tried way back, and similarly we didn't get good efficacy, and also we got a lot of toxicity because we use a special agent and that BAK. So we in fact ended up with some patients with haze, and it was very frightening in our early days. And so it's exactly identical to what Dr. SKR said. Can I make one sort of an observation when Dr. SKR said about the collagen turnover? So I was putting together a chapter on histopathology and looking at the etiopathogenesis of Keratoconus. And in that, as Dr. SKR said, that nobody knows what is the turnover time. And the second problem is that there is a sort of a subclinical immune mediated mechanism as well. So even if we have something like the turnover is 3 years or 4 years, but it's an individual patient's genome that will decide whether it's earlier or it's late. So it's not an average. You can have an average maybe, but it's not the same. There are two ends to it. It can be very short, 2 years. It can be very prolonged, 7, 8 years, 10 years. So there's no answer to that. But coming back to the protocol, same as Dr. SKR. I'm curious, why do you, and even Shubhangi indicated, ask the question, do you vary the protocol for pediatric patients or based on the severity? Is there a reason to ask that question?
Yeah, because some of the articles say that the classical resident protocol of 30 minutes is preferred over the express technique because you get a better result. So that's why I asked you.
Okay.
I think the duration of the accelerated protocol might be important. Anything less than 10 minutes may not have good outcomes. That's because the oxygen regeneration time is not there. So you don't get the aerobic mechanism, you get more of the inflammatory anaerobic mechanism, and it's also not as efficacious. So I think there are papers which show that once you go to 10 and beyond, it is comparable to the Dresden protocol.
And so there are some articles which also mention that when you're doing an epi-on treatment, you should increase the fluence. So instead of using a 5.4, you should increase your energy by 20% more because there is a loss in the epithelium. So has anybody tried that, or is it? I don't know. I just had this question because there are people who still do epi-on treatment.
If you have 10 surgeons, you'll have 11 ways in which they will do the cross-linking. I don't think there's any standardization as yet. We just talk about it, but then each of us has our own ways, and I think there will be minor variations. So yeah, the increase in fluence, it has been described, but I think those are small reports, case series. So I don't think it's widely followed or widely practiced.
Dr. Nikhil?
I do standard Dresden protocol, and actually I wanted to ask Parul, you also could chip in with your technique.
I'm using the express only. I'm not using the conventional now, obviously because of the time. But I have seen only 2 patients of recurrences so far in my whatever practice that I had. But both the patients actually had recurrence after 10 years. So I have not seen a very early recurrence except in one case of post-LASIK ectasia and a very late post-LASIK ectasia showing a recurrence. That is also not during pregnancy. Post-pregnancy, during lockdown, she had a lot of rubbing of the eyes and she progressed. The moment she stopped rubbing her eyes, her progression stopped. So none of my patients that I have really retreated them. I don't know. I'm still not open to a retreatment. I still believe that I should try to modify the risk factors. And if they still progress, then maybe yes, we go ahead and do the treatment. So
just wanted to ask a question. During cross-linking, sometimes we have drastic flattening of the cornea. What could be the reason for such erratic responses in some subset of keratoconus which are treated with cross-linking? Rao sir, what is your take on this?
I don't know. I've had those patients. They've progressed continuously in terms of flattening for 7, 8 years, and they still haven't stopped, some of them. So probably what Dr. Sheila was saying about some autoimmune process in terms of the way the keratocytes react to the cross-linking process when you destroy them. Maybe this regeneration is not as good. Like I said, there are 14 patients in this series that I've done where they've gone down to desmetocele formation spontaneously over the years. and we've had to do a DALC to support the cornea. So the ultimate take-home message is, while cross-linking is the only tool we have at the moment to stop progression, I don't think we should by any means imagine that it's an innocuous or an innocent procedure. It has its own share of major pitfalls. So be very careful when you do it, particularly in eyes which present to you with 6/9 or 6/6 vision. Because this kind of flattening, if it happens in them, they will lose vision. And then we will be, it's not a nice thing for them and for us.
So these patients with scarring, what was the age group that you saw? Because I also saw 2 patients, but they were all where the cross-linking was done at the age of 35, 40. So these were the patients who really had very bad scarring and continuous regression. So what was your...
No, these were all done in their early 20s, and then they presented at various periods of time, somewhere between 4 to 7 years after the procedure. They ended up with this continuous thinning and melting. Not really melting, it's just that it's optically empty cornea there. Basically, no collagen, no cells there. And at some point, the epithelium breaks down and you get almost like, a cavity there, it's going away. So very difficult. I call it corneal sclerosis. I can't think of a better way to describe that.
So, Dr. Somshila, do you think a repeat cross-linking can exaggerate this kind of a scarring? So when we know that CXL can give rise to corneal scars, and when we are retreating these patients, do we run with the risk of scars in these patients?
I don't know the answer to that. The cases are very few and we have not studied it. But my bet is on the fact that there's apoptosis and that kind of never recovers or something like that. It's like an irradiated tissue. There's literally, we have irradiated tissue. So it's something there, some phototoxic permanent damage to the keratocytes, and they never replenish or regenerate. So yeah, so obviously in a predisposed individual, when you repeat the cross-linking, we're exposing that risk. Maybe it'll happen faster. It's just presumption. And also, just like Dr. SPR, in our series, though we're trying to publish, we're not published, even our repeat cross-linking is very low. So it's certainly not like this article where they had 8% or something like that, 10%, 8%. In our series, it's probably around 2-3%. That is repeat cross-linking. Not to say that they have not progressed. Progression would be a little higher, but exactly as you said, so very, very, very conservative when we plan a repeat cross-linking. So we look at the trend, like Nikhil mentioned, and we don't rush and offer cross-linking till we're very, very sure that it's a continuous process.
Could this scarring be because of more of lysyl oxidase present in the cornea, and the amount of disease is very mild in these cones? That's why the scarring is more aggressive? Or the cross-linking is more aggressive? Because more severe the keratoconus, less the amount of lysyl oxidase. And what I mean to say is, are we over-treating keratoconus and over-diagnosing, and we are treating some subsets where the cross-linking is really not needed and we are cross-linking them?
You may be right. I don't know the answer to the lysyl oxidase question that you posed, but I think you may be right that we may be over-treating, because in some of these patients where I had actually advised both eyes to be treated, I did the one eye, and for some reason they refused the other eye and they went away. But then they came back 5-6 years later, and the fellow eye, which did have a cone in which I had recommended a treatment, was stable all through these 5 or 6 years. And sometimes the treated eye actually had the flattening that we saw and didn't do as well as I thought it would. So now I think the conservational thing in terms of recommending cross-linking has gone up quite a bit after I analyzed my data. So I no longer will recommend it off the bat. And now more on the back foot with cross-linking.
Sir, in advanced keratoconus, prior reshaping of the cornea and then following the CXL has been advised in literature. What is your guidelines for that?
So there is an alternative therapies which are available now, Bowman's layer transplant, and then stromal inlays. So can we offer these treatment as an option, alternative to C3R, a repeat C3R?
In a subset, I think, yes. Certainly not just the Bowman's layer, but Bowman's with stroma, because the Bowman's layer, we tried that and it's technically very challenging.
Yeah.
Yeah. So Bowman's with stroma it's a very simple premise that you have a thinner cornea. So you're augmenting it, and then we cross-link it as well. So, but just like what we had seen with anterior lamellar keratoplasty, that the topographic results are variable. So sometimes you may get visual improvement, sometimes you may not. But it looks very good on the pentacam or on whatever device you measure it. But it may not always translate into good visual acuity. But it's definitely that's something that they've started. A few of us, Dr. Vikas Mittal has quite a good series of patients now, and he's almost on the verge of making a sort of a protocol about how to go about these cases. So we should wait for those publications.
So you are offering this as an alternative therapy to C3R in some of the patients? So I understand.
We have an ongoing study which is not on corneal tissue, but which is on collagen and other in the material.
Collagen, yeah.
Yes, yeah. So proprietary material under study. So we are offering that, and we've seen fairly good results. We're still working it out because it's the second or third iteration that's going on now. It has its own set of problems.
Okay.
Any other questions? Because we are almost,
Yeah, we are almost there. But so what method of would you prefer to diagnose a progression? So when you look at pentacam or you are looking at a surface topography more, so what is the preferred method to document a progression? So one, the machine which you have it in your clinic, or you would recommend any of the machines?
Placido is equally good in looking at progression. I don't think it's any inferior to a Scheimpflug. If you have a good Placido map, you can definitely use it to document progression in terms of curvature, but you won't have your pachymetric maps on it. So that is useful as well in terms of the actual thickness progression, in terms of the position of the thinnest point. And of course, don't forget vision and don't forget qualitative issues. The patient will tell you if he's feeling the same or not. I pay a lot of importance to that.
So you always will take a pachymetric data along with the surface changes, because there are some cases where you may not see the pachymetry changing too much, but you do see that the cone is progressing in terms of the area. So you see a globalization of the cone, but you don't see pachymetry going too much on a lower side.
I think two categories. If you're talking about a primary cone, I think this data is really useful in a Scheimpflug. Basically, we're not doing central pachymetry manually. But post cross-linking, I think the relevance of pachymetry is a little more debatable, because as we said, there are some corneas which thin and they flatten and thin. So the thinning alone there it's not really very relevant. So if you're looking at a primary cone, I would pay a lot of importance to the thinning, the location, and so on. But if I've cross-linked the patient, then the thinning is not so important for me.
Yeah. So do we have any other comments or questions from the panelists or the other people in the group? Because we have shooted our time. So what is the take-home message? Last one.
Last take-home for everybody. That's what I was going to ask. Actually.
Yeah.
I think we need to stress that C3R patients need monitoring. That's the first thing, because very often you find they're orphaned after the procedure is done by the surgeon, and the patient is not aware that follow-up is required and the procedure can fail. So I think that's the first message that we need to send across to all our colleagues. Sometimes I find that that's not happening.
Okay.
Yeah.
Dr. Rao sir, you want to say something?
I think exactly like Nikhil said, I think this is just one option in the spectrum of treatment of a keratoconus. So just having access to a cross-linking, I think, is not a very complete or a holistic way to look at these patients. So you need to have other options open to you, including surgical options. And like I said, I've learned not to be very aggressive with it over the last decade or so that I've been doing it. So now I approach it with a lot of respect and caution. So I do it. I'm not saying I don't do it, but I think my index for doing it has gotten a lot higher over the last few years, particularly after I analyzed my data. So those of us who are doing it, I think it will be very useful and eye-opening to go back and look at your data. I think that's what happened for me.
I think with this, I think we'll just end this session. So, Vaishal, Thanksgiving.
Yeah, sure. So it was a very interesting, and the deliberation by all the stalwart faculty was very good. I thank Dr. S.K. Rao, Dr. Somashila Murthy, and Dr. Nikhil Gokhale, and Dr. Shubhangi Nigwekar for having a brilliant talk today. And I would thank Dr. Parul for weaving all of them together. And I thank MOS and BOA for giving us this platform. I thank Dr. Santosh Bide, Dr. Imanshu Mehta, and Dr. Sabyasachi and Dr. Siddharth Kesarwani for a brilliant statistical analysis. And Dr. Zain Khatib and Dr. Neeraj Israni for their contribution for social media networking. And I thank Entod for giving us this platform and sponsoring this webinar.
I think the presenters did a wonderful job as well.
Yeah, they did.
The presenters, Akshay and Rohit, both of them, you are brilliant.
Yes.
Brilliant, absolutely brilliant.
Excellent session, and thank you on behalf of Maharashtra Ophthalmological Society to all the panelists, Dr. Srinivas Rao sir, Dr. Somashila Murthy madam, Dr. Nikhil Gokhale, and of course, Dr. Parul Deshpande for choosing this topic, Dr. Vaishal for being so enthusiastic and always with us, Dr. Zain Khatib. It's an excellent initiative, and you have this again after 2 months.
Yeah.
Right?
Yes. Right. We'll be having on the 28th of June.
28th of June, and the topic will be shared later.
Yes.
And do share your feedbacks also, everybody, and do suggest the topics also. Thank you once again, Dr. Parul and Dr. Vaishal for being.
Thank you so much, everyone. Thank you so much.
Thank you.
Thank you.